Hi everyone, welcome to another Fertility and Sterility Journal Club Global. And today's is truly global. We're coming to you live with a European group of panelists and discussants. My name is Pietro Bortoletto. I'm the Interactive Associate in Chief for Fertility and Sterility and Media Editor for FNS Reports. And today I have the privilege of not hosting and actually turning it over to two people who some of you know very well, Dr. Paul Pirtea and Dr. Dom de Ziegler. Paul serves as an interactive associate for Fertility and Sterility, and Dom has served in multiple roles through Fertility and Sterility, but currently an editorial editor for FNS. Today we're going to be discussing a really cool topic, something that I think gained a lot of traction once it was published, something that I think clinically, academically, we've all been talking about and wondering, and certainly our patients are asking us. The question is, does diminished ovarian reserve impact embryo aneuploidy or live birth rates? And it just so happens that we have a wonderful paper from FNS published by Dr. Yuval, who's one of our panelists today, to discuss this exact topic. I want to turn it over to Paul and Dom, your hosts for the evening, and I hope all of you enjoy tonight's Journal Club Global.
Thanks, Pietro. This is fantastic. This is another Journal Club in Europe. It's dark here. It's the evening. And I'm going to hand over the mic to Paul, who is like me at Hôpital Foch in Paris. And I just want to convey that we have good news from Dr. Micah Hill, who is doing better and is going soon be with us again. So Paul is going to actually present the authors who themselves will present the paper. Great topic. Quantity and quality. This is what it comes down to. And then we're going to discuss that paper and going to discuss the results. Paul, the mic is yours.
Hello, everyone. So actually, we are quite lucky to have the authors here with us today. So they will be presenting their results and conclusions. As mentioned by Pietro and Dominique before, this is a very cited and discussed, debated paper. So we are going to start first with Denis Vaughan, who is actually a reproductive endocrinologist at Boston IVF and Betty Soil Deaconess Medical Center. He's also actually an instructor at Harvard Medical School and the director of clinical research at Boston IVF, who will conclude the results that will be presented first by Yuval, which is actually an OBGYN from Tel Aviv Medical Center and currently working as a research fellow of Boston IVF. And he's studying quantitative methods in the MPH program at the Harvard Chan School. So please, Yuval, present the results of your paper, and we are looking forward to debate on them.
Thank you very much. Hello, and thank you all for the opportunity to share this work with you. So in this work, as you mentioned, we were trying to assess a long-standing debate about ploidity rates in patients with diminished ovarian reserve and also with patients diagnosed with poor ovarian response. Specifically, we were trying to account for the inherent design difficulties that arise when you explore this topic. So we can start, I guess. The presentation is on air. Great. So embryonic aneuploidy, we can do the next slide. Embryonic aneuploidy results from several types of chromosomal segregation errors, and those segregation errors affects an exceptionally high number of human conception. They cause infertility and miscarriages and congenital disorders, and those segregation errors basically have a distinct age dependencies, which impacts our reproductive lifespan. And in this sense, diminished ovarian reserve is a source of stress for patients, but it's also a management challenge for the practitioners. It is still unclear whether patients with DOR show their poor reproductive outcomes due to their lower ovarian response, or whether there is an additional qualitative morbidity, which could maybe translate to more genetically unbalanced embryos. So patients, and indeed many physicians, incorrectly conflate oocyte quality and quantity, and the consequences of that could be missed opportunity for childbirth with the autologous oocytes. And next slide. We performed a comparison of aneuploidy rates based on propensity score matching. We used a large retrospective data set of patients younger than the age of 40, which were diagnosed with diminished ovarian reserve, and poor ovarian response to stimulation as a secondary analysis. Additionally, we compared live birth rates per transferred embryos and focus on the events of cycles that ends up with no euploids to transfer. We can go next slide. In terms of study design, our study period was between 2014 and 2020. We have used only next generation sequencing platforms. And the study, basically the study started with 2,200 patients roughly under the age of 40 in their first IVF cycle. Of these patients, 383 patients were diagnosed with diminished ovarian reserve, and 143 patients were diagnosed with poor ovarian response. The criteria for DOR were clinician diagnosis in charts, codes, and an AMH, additional AMH cutoff of less than 1.1. For the first primary comparison, that was the DOR versus non-DOR, patients were matched in a ratio of 1:2, and for the POR group, the poor ovarian response, the matching was 1:4. And next slide. So we used propensity score matching as a statistical technique to construct an artificial quote-unquote group by matching each treated unit with the non-treated unit of similar characteristics. Using those matches, we could then estimate the impact of the exposure, which was in this case the diminished ovarian reserve diagnosis. So we chose age, BMI, and cycle year as covariates in order to avoid an unbalanced model. Let's talk about our results. For the propensity score matching is basically the new output sheet here, and we can see the characteristics of the DOR versus non-DOR patients and the matched populations, which were matched successfully on the top of the table. And as seen in the post-propensity score, the unmatched characteristics, such as the ovarian markers and the cycle performance, AMH, AFC, FSH, and the stimulation, still differ between the group, as obviously expected. The aneuploidy rate in the given stimulation, it's still the previous one. The stimulation cycle between the DOR and the non-DOR group did not differ significantly after applying the propensity score matching, and the rate was 42.2 versus 42.1. So for this specific comparison, even though that it's part of the table, we performed a Poisson regression analysis of aggregated data in order to model the total number of embryos biopsied in so-called offset. That means that we wanted to see the clustered embryos between each subject that obviously differs between those two groups. The mean time couples attempt to conceive did not differ between the groups. It was 40.1 months versus 13.3. Having this new matched population set, we wanted to check for several potential classifiers, as some have been previously mentioned to be potential surrogates to ploidity. So first we went to check AMH for correlation with ploidity. The AMH was divided into 3 subgroups by percentiles: less than 25 percentile, between 25 and 75, and more than 75. And after age adjustment, there were no differences in the ploidity rates. And that was also reported 2 years ago in another study. Next slide. As to fertility outcome, our results show the same per transfer rate. As you can see, we had similar per rate miscarriages and pregnancy rate. And when it comes to cycles that ends up with no euploids to transfer, those were actually higher. The crude number was actually higher in the DOR group. However, next slide, when we plot the expected frequencies of those scenarios of cycles that ends up with no euploid to transfer, we can see that in each group, the two polar condition, all euploids and all aneuploids, were both fairly frequent and much more frequent in the DOR group. And the reason for that was simply that the mean number of biopsied embryo per subject were lower in the DOR than the control. Therefore, the observations of cycle that end up with no euploids to transfer is basically the numerator and not the denominator. It's basically what the patient feels. So after adjustment for age, BMI, there were no differences in ploidity rates here. So to conclude, our result indicates that patients diagnosed with diminished ovarian reserve who achieved into blast stage have the same chance of achieving euploid embryos to their peers in the general infertile population. And once an embryo is transferred, blasts and biopsies, there is a similar live birth rate. Thus, the true rate limiting factor of achieving live birth in those specific patients would be the extent of their response to stimulation during a given cycle. Moreover, patients should be informed and reassured that cycles that concludes with no euploid to transfer are the mere results of their lower ovarian response and are not associated with any qualitative morbidity or reduction. Thank you very much for your interest in this work. Thank you for your listening.
So Denis, can you conclude on these results, because they are very important for our field and for the clinical work that we do every day with our patients?
Yeah, terrific. So I think the big take-home message is that in patients under the age of 40 who can obtain a euploid embryo, they can be reassured that their embryo is as likely to be euploid when biopsied if they're able to achieve that blastocyst, which, as Yuval said, is a challenge in itself. But once we've obtained a blastocyst, as likely to be euploid and subsequently as likely to end up in a live birth as somebody without diminished ovarian reserve. And so, you know, obviously we're going to get into the nuts and bolts of the study, but just a couple of things to point out up front. You know, I think that we have some limitations in that obviously it's a retrospective study. The patient needed to have one blastocyst to biopsy in order to include them in the study. And as we know, that can be a challenge for patients with diminished ovarian reserve to make a blastocyst. However, we did look at blastulation rates between the two groups, and they were similar when we used 2 pronuclei embryo as our denominator. And also, we didn't report mosaicism and that's a Boston IVF protocol. We don't report mosaicism, but we know from work by Carlos Simon and others that low and medium grade mosaic embryos behave as well as euploid embryos. And so each of the labs that we used have their own various cutoffs. Most of the embryos in the study were analyzed by 3 main labs, but we know that there are some differences in ploidy rates according to the lab analyzed. So there are some limitations there, but overall I'm excited and happy that this journal or this article was chosen for this journal club, because I do think it adds to the existing body of literature to reassure these patients. And as Dr. Falk said, there are patients who won't get a euploid embryo, and they're more likely in these diminished ovarian reserve group. But we know, again, from a great article by Richard Scott earlier this year in FNS, that those patients can cycle again, and they're no less likely to get a euploid and another cycle without a euploid embryo. So patients should be reassured overall that if they don't get a euploid embryo, they should be encouraged to try again if possible, if they feel up to it. And if they do get a euploid embryo, that their outcomes are the same as somebody without diminished ovarian reserve.
Thank you, Denis. So actually, yeah, we chose this paper because we think that it's relevant and it is clinically useful, and that it should reach out to as many specialists as possible, because it could be the patient needs to be reassured. But we're going to start the debate. So I will first introduce you Shari Mackens, who is actually the medical director and clinical professor at IVF Center of Reproductive Medicine at Brussels Free University Hospital. And she actually has a specific interest in translational research, focusing on the role of the neuron in ART. Not the case right now. This is about the embryo. So Shari, what are your takes on the results and this paper?
Yeah,
Before Shari starts, I just wanted to make one comment for the audience. You can actually have access to the article, which is published in FNS, and you can download the article. So check by yourself the facts. And now Shari has her comments to make.
Yeah, thank you, Paul and Dominique, for the introduction. I'm very happy to be with you tonight, and congratulations to the authors. I first would like to compliment you with your work. As we said before, it's very important data, especially to counsel patients, of course, who are scared when they get this label of a diminished ovarian reserve. So it is extremely interesting that we have this reassuring data from your study after the matching that you performed, taking into account the pitfalls of the retrospective vision of your study. Very interesting data. However, my main question and my first question when I saw your tables and your article is what we also see in daily clinical practice, which is how difficult it is to label patients that never went through IVF to have diminished ovarian reserve. You included them before their first cycle. And then what you see actually is that they had quite a nice number of oocytes. They have 9 oocytes at the moment of pickup, probably because indeed you select the ones that did have embryos to test for PGTA. So how do you think that we could improve this also for the future, this labeling of a diminished ovarian reserve and really estimating how patients will perform after stimulation? It's really a challenge for clinical practice. And do you think that this patient population that really has a diminished ovarian reserve, do you think that you really capture them within the data that you have now?
So thank you very much. That's a great question. So I think that in terms of your first question about how did we determine pre-cycle the diagnosis of DOR, I think that was the main importance here, that we have picked them up by the AMH, AFC, and FSH level, and then by this let's say by this medical determination reevaluate them almost blindly. But our second please remember that our secondary analysis was actually the POR, the poor ovarian response. And in those cases, basically, as we can see in the study flow chart, we have almost validated our results, and they were practically identical in cases of DOR and POR. And there was also a population overlap between those two. And the fact that we got the same statistical and clinical inferences for those groups is actually pretty reassuring, first for the clinical designation of the very definition of DOR, and second for the validity of our result.
Yes, exactly. I think that you did a very good job with looking at diminished ovarian reserve, but also your second analysis that you did, where you really looked at the outcome. I fully agree with you that this really strengthens your message. Another question, well, that I ask myself when I see patients at consultation is whether I should take into account their reason of having a diminished ovarian reserve. I imagine that a patient that has a diminished ovarian reserve iatrogenically after an operation for endometriosis, for example, can be a completely different patient than somebody who has no surgical history and where we cannot really pinpoint the reason of having a diminished ovarian reserve. Do you have any ideas on how we could have other approaches towards these different kinds of patients?
I would like before you answer, I mean, this is an excellent question. Excellent question. I would like to expand. Did you check for smoking? Okay. Now in Europe, I know in the US people don't smoke anymore, but in Europe, people still smoke. And this may have an effect on oocyte quality, and this may actually be different than women who've had, as Shari said, surgery for endometriosis.
That's good point. I think just to back up to the original question, you know, the pre-cycle diagnosis of diminished ovarian reserve is notoriously challenging. And, you know, clinically, we at, you know, Boston IVF will, in order to assign somebody a diagnosis of diminished ovarian reserve, we really try to look at the patient holistically, and not just one isolated data point. And so typically, you know, for this study, we use AMH of a 1.1, but also the antral follicle count is taken into account. Also the FSH is taken into account. But to both of your points, the underlying rationale or reason behind the diminished ovarian reserve also has to be taken into account. And like Dom said, fortunately in the US, the smoking rates are extremely, extremely low, at least tobacco smoking. Now marijuana smoking is starting to increase. But in our population at Boston IVF, it's only about 1% of the population that smoke, or at least that report smoking. And so that in itself is unlikely to play a huge role. But other reasons such as previous exposure to gonatotoxic therapy, for example, that's a reason patient may have diminished ovarian reserve and may also affect egg quality. But overall, I still think that, you know, age is going to be the single biggest predictor of outcome here, irrespective of ovarian reserve.
Sorry to interfere, but the question is, why did you put the cutoff at 40? Why didn't you go to 42 or even more?
So yeah, that's a great question. So we have, like in my head right now, there are 3 major studies around this topic. One picked up the age of 40, the other 38. And there is but you're right, there's additional one who picked up 42. It comes again to the broad and heterogeneous definition of DOR. There is no specific agreement about a specific cutoff. We have chosen 40, as most of the studies have previously chosen 40. And it's important to mention that we haven't done any variable screening or pre-analysis or on our own material to pick up this threshold. We just pick it by literature knowledge.
Yeah, it's somewhat arbitrary. You know, granted, our blastulation rates are going to be dramatically lower in the patients over the age of 40, and our aneuploidy rates are going to be much higher. But it is somewhat arbitrary choosing 40 as a cutoff.
So I have some more questions, but Shari, yeah, go ahead, please.
Yeah, it's probably a very, very difficult question, but you had this number of patients, and I guess that you started the retrieval of your patients with the embryos that were there for biopsy. Do you have any estimation when you take the same parameters for your diminished ovarian reserve population, how many more patients you would have? It's probably very difficult to have an idea on this and to retrieve them, but do you have any estimates on that?
We didn't look for this particular study. We didn't look at it, but it is a really good question, and I'll pose this, I guess, to the group in general. If we were to design a retrospective study to try to delve a little bit deeper from almost like an intention to treat analysis, how do you think that best would be achieved? Because obviously we recognize the limitations in choosing those patients who only make a blastocyst. How would you guys go about analyzing a large data set to try to get down to the core question here, which is the oocyte competence in these patients with diminished ovarian reserve?
Okay. We're gonna address
the author who is presenting his paper is now asking questions. This is a reverse order. The participants have to answer, I guess.
I always like to be contrarian.
Yeah. So we're gonna give leave Cindy Argento to actually debate also on your paper. So Cindy is actually a fertility specialist in Clinica Valle Giulia, Genera Life IVF Rome. So she's there since 2018. And then before that, she was actually for 10 years in Modena. Well, everyone knows what Modena is known for. So Cindy, please, well, try to debate the paper and maybe
Yes.
answer Denis on the question he had.
I have to thank you for inviting me here. I'm very excited to be here, and I'm very happy to discuss about this topic because it is so actual, it's so important. One thing I would like to say, yes, I think one of the main features is actually the definition of these patients, you know, the diminished ovarian reserve. We have a very particular setting. You know that Italy is probably one of the places, one of the countries where couples decide to have children later. So that in the first place is a problem, it's an issue. Patients that, the mean age of patients that we see in our clinic is 39.6 years old. So our population is generally diminished ovarian reserve because of age simply, even if we don't want to look at other features for their infertility. So we have, I'm very happy about this paper because this expresses exactly what we see every single day. And the data that come out of this beautiful work is actually what we see, and it confirms what we find in our general clinical practice. I think the main issue is actually that these data are so important to counsel patients, because even if they are actually coming in for their first treatment ever, although I must say it is not, it's often not like this in our setting, because being a private clinic, many couples have already undergone other treatments elsewhere. But apart from this, we have, I think, we have to counsel patients, and the first thing we have to tell them is actually that, yes, you don't expect to come in and just say, I do the treatment, it's either yes or no. No, we have to make them understand that it's probably a journey they are starting. And these data actually help us to correctly counsel couples before starting. We have enough evidence now to assume that although their ovarian reserve may be diminished, although their age may be not so young, they still have the possibility to achieve a healthy embryo, and their history of diminished ovarian reserve has no impact on their live birth rate. But this can help us to actually find strategies to avoid patients like dropping out after the first cycles, because either they haven't obtained a blastocyst at all, or they have obtained a non-healthy blastocyst. You very well know that we work a lot with the double stimulation protocol, and that helps us a lot because it actually gives us a chance to accumulate more oocytes and more blastocysts to test, and eventually to have more euploid blastocysts to transfer in these patients. So it's thank you, because this actually helps us to show patients that there are consistent data showing that they have to go on, and continue with maybe more than one treatment, but they have a very good possibility to achieve euploid blastocysts, regardless of their diminished ovarian reserve in the first place.
I would like to make a comment, just not a comment, but a request to Cindy. You talked about dual stimulation. Do you want to say just a couple of words about that? Because I know that your group has been working a lot on this. And
yes.
I think it's important when you go ahead and just tell people what it consists in.
It's actually the possibility to do two subsequent stimulations in the same menstrual cycle, starting on day 2 with a conventional stimulation and doing a normal egg retrieval when it's supposed to be done. And then 5 or 6 days later, after the egg retrieval, we start a second stimulation on the luteal phase, because we have seen, and data have shown now they're not very, I mean, they're now very consistent that the eggs retrieved are pretty much the same or even more in terms of number, and the blastocysts produced from the 2 cycles then are pretty much the same as far as quality, as far as euploidy rate. So that means that patients that have a diminished ovarian reserve or a high age can have lots of advantage in trying to do actually 2 cycles in 1 month. And apart from the fact that they actually can retrieve more oocytes and have more embryos, it actually reduces dropout, because once they start, they're actually, you know, on the run, and it helps them being consistent on the treatment till the end of the 2 stimulations. And it's giving us lots and lots of satisfaction, I must say.
Great. And I think just to comment on what Cindy just said, I think part of our job as reproductive endocrinologists is not just to choose, you know, the optimal protocol for the patient in order to maximize outcome, but really to support these patients through the journey, you know, without giving them false hope, but be able to predict and realistically predict their outcomes, and just make them aware up front that this is not likely going to be a one and done situation. They're likely going to have to go through multiple cycles, so that they are comfortable and accepting of that fact up front, and they're not shocked when the first cycle doesn't work out as we might hope.
Yeah.
So Denis, I'm going to try to address the issue of how to assess the data. So I fully agree with you on the topic that data on DOR is very complicated. First of all, the criteria for DOR were arbitrary. So we just like put a cutoff there and we assume that that's the real case. But data, even today, after the Bologna, the Poseidon and everything, data on DOR is very, let's say, non-conclusive. And it seems that from what I've seen and read, that most of those patients behave much better on a second cycle than the first one. So if you were to say, like you talked about your limitation by the fact that some had the first attempt done and probably behaved better than you estimated based on AMH, FSH, follicle count, is that in the end, you can never get to the bottom of it, because maybe in the next cycle, they will even do better than the first one. So I think it's something that you cannot control for. And I think that between DOR and POR, so diminished ovarian response, poor ovarian response, there is also a big difference, because your diminished ovarian response is based, for example, on AMH, quite variable. Some patients don't really act. Of course, AMH is important, but not that precise, like 1 oocyte or more. And also, in some patients, maybe you have, let's say you had more oocytes, but doesn't mean anything. They don't fertilize. And this is why, for me, the fact that you calculated for blastorization rate and fertilization rate was quite convincing. So I do not have a clue on how to ideally calculate the data. Actually, I'm very happy with what you did, and I probably would have done the same if I would have thought of it. My only question is around the mosaics, because so we are talking about limited embryo patients, so we don't have that many, and you have excluded mosaics. And you know that nowadays those data that show that some mosaics in plant are true, but they also say that some mosaics are actually euploid. So it seems like 20 to 30% of those embryos who have been labeled mosaics with the new techniques, the new logistics, they seem to be euploid, and that actually I mean, it's 2018 in your data, but there are laboratories that actually right now they acknowledge the fact that due to the pressure of having to deliver a precise result or label for the embryo, in some cases where they were like non-conclusive or anyway signs of not euploidy, they label it right away aneuploid or mosaic in this case, and therefore they would not have been included in your data. What do you think?
I think, you know, ultimately that comes down to a limitation of the testing technique itself, right? We know that PGTA by trophectoderm biopsy is not perfect, and we're trying to make a generalization from 4 to 6 trophectoderm cells of the general representation of the entire embryo at a particular snapshot in time of development of that embryo. And we know that there can be changes in the relative proportions of aneuploid or different cell lines as the embryo grows and develops. And so I think ultimately, you know, that's one of the strengths and limitations again of this study, is that, you know, maybe looking at aneuploidy rates by trophectoderm biopsy isn't the end all and be all. Ultimately, obviously, is take home baby, and looking at a study like this in embryos that are just transferred rather than going through PGTA in itself would be interesting. But that wasn't the question here, because PGTA is so commonly used in the United States. At our clinic, actually, is a little bit less than the average for the United States. We do PGTA in about half of our IVF cycles, but it's not a perfect test.
But do you think that would have changed the conclusion?
I don't think so, because it should be evenly distributed among the groups. I really don't think that would have changed our outcome dramatically.
Even if you include, sorry, interrupting, even if you include mosaic in your study, of course, it's a trade-off, because you can end those and have a different denominator. However, when you do have mosaics and you discuss with the patients about the mosaic and you have different lab with different thresholds, it's kind of a different story when you compare it of being blind to all of that. It's quite of less noise in your data. Your data without everything is just, it's not pure. It have, of course, its limitation. But on the other hand, there is also a counter argument for including various types of mosaics, various types of call rates, the discussion itself with the patients. Do you agree to transfer this kind of mosaic, yes or no? I think it will add more confounders to the issue. It will be an advantage also.
Yeah, I agree. It's a trade-off, and not every patient will be comfortable transferring a medium mosaic or a high mosaic, and that in itself would change our live birth rates at least.
I would like to, sorry, I would like to, for a second, to get back to the issue of quantity and quality, because we talked, I mean, the essence of the paper is to really convey the message that when quantity is diminished, quality is preserved, 48, okay? So that's very well taken. That's the essence of the message that you are conveying. My question is, there were data, there was particularly one very spectacular seminal paper by the group in Belgium, which concluded that irrespective of how many eggs you get the retrieval, you approximately need 20 oocytes for a baby. Do you have any idea in the numbers that you got? I know it's not discussed in the paper itself, but did you have any idea as to whether this quantity issue remains a parameter for ART efficacy?
So we previously looked at, you know, trying to come up with an optimal number of oocytes during an IVF cycle, and we've previously demonstrated that even if the relative efficiency decreases as the number of oocytes increases, the absolute number of embryos is still higher, and therefore you have more embryos available to transfer. So if we look at cumulative live birth rates from one retrieval, ultimately the more eggs that we can retrieve, the likelihood is that will correspond to a higher number of live births per retrieval.
So I'm sorry to bug in, but so given your experience now that you've looked into this data, given these patients with DOR, POR, what would be for you the incidence of recurrent aneuploidy, complete aneuploidy? Because this is like a more clinical question, because the question is you do an IVF, you have nothing to transfer, you do the second one, you have nothing to transfer. When do you start to worry, or what's your take on it, or the likelihood for you to believe that this patient will achieve someday to have euploids to be transferred, given that it's a DOR, POR patient?
That's a good question. You know, I think looking at Richard Scott's paper, at least 50% of the patients who didn't get a euploid embryo on their first cycle subsequently had a euploid embryo. So I do really think that for the majority of patients that it's a numbers game, and that if you do enough cycles and they're getting to embryo biopsy, that it's only a matter of time before they get a euploid embryo. Now it's a very different situation for patients obviously who cannot make blasts, but I do think that, at least when I'm counseling my patients clinically, I do encourage them not to read too much into a single cycle or a single data point, and that it's really the pattern that's emerging from the behavior of her oocytes across several cycles that would lead me to conclude her overall prognosis.
Yeah.
Cannot agree more.
I fully agree with what Denis says. So in Brussels, we're not working in the PGTA setting. It's not common to test our embryos, but you feel it clinically that when your patient has the potential to develop a blastocyst, then they keep on getting these consistent chances to conceive with a morphologically normal blastocyst. You just have to take into account the 40–45% aneuploidy, of course corrected for age, that Yuval and Denis also show in their paper. So you need more embryos because you do not see their aneuploidy. But when you have blastocysts and when you continue, we also see in our clinical data that their implantation rates and their live birth rates, that they stay consistent over multiple cycles. And this really relates to your paper as well, Paul, where you checked your consecutive euploid embryo transfers, where we see quite consistent chances, and it's a play of statistics. And I think that this play of statistics is really the answer for many of the questions that we are answering in today's clinical research questions.
Yeah. So Dominique and I were talking today. Dominique, do you want to have a word on the paper that we discussed today?
Well, yeah, we looked at a paper that came from Italy, from Antonio Lamarca, who at first glance seemed to indicate opposite results. But when you look carefully, this is an article that came out in Human Reproduction, but it actually looked at the chances of having one euploid embryo. And in that paper, they conclude that with diminished ovarian reserve, you have less chances. Goes back again to the issue of quantity and quality. Of course, if you have less 2PNs, less embryos to begin with, your chances of having one euploid is going to decrease. But as you said, the euploidy rate or aneuploidy rate is not modified. So I want to convey this, and Paul is right, because this is an article that came out at about the same time and gives the false impression that it is providing results that are in conflict with those of the Boston IVF group. I don't think so. I think it's a different perspective, and I don't think it's the right perspective either. So actually, those are my thoughts about this article. It's important to say that because some of our people in the audience may have been aware of that article. And I don't think that it stands in opposition. It's just a different look at, and it's a look that confounds the issue of quantity into their results. You probably read this article. So you want to comment, Denis?
Yeah, I agree that that paper is slightly different to ours, and I don't think that it is exactly contradictory. And I think that there are many other papers that have been published in Fertility and Sterility that show slightly different results to ours too, but it, you know, every paper is not without its limitations. We've acknowledged ours, but I think it is interesting and it is important for us to have different results among different groups, because it gets the conversation going, stimulates discussion, and moves us hopefully closer to the ideal study, or to get the ultimate answer, because as we recognize, nothing is perfect and not all results are generalizable across different populations.
I would like to expand a little bit your conclusions into a practical issue, which is that of fertility preservation. We have more and more women. Sometimes the cost is covered by an employer, like Amazon or whatever, to actually undergo fertility preservation so that they're not disrupted from working and they can postpone childbirth. Now, at one point, there was a concept that if AMH is low, they shouldn't do that because it ain't gonna work. Do you want to comment on that? Because that doesn't seem to be true.
No. Well, honestly, I think the efficacy of the oocyte preservation is age dependent. I mean, if I have a 30-year-old or 32-year-old and she has 4 or 5 antral follicle count and a low AMH, I will do it. Maybe I will do 2 retrievals, but I will definitely try and, you know, push her to do it. Even more, because if she has a reduced ovarian reserve when she is very young and she postpones childbirth, when she gets to, you know, the time when she would want to have a baby, the situation will definitely not be better. So absolutely, yeah. And I think it is age dependent more than AMH dependent, because if I can, you know, I have an older patient who wants to freeze her eggs when she's like 39 or 40, even if her AMH is average and it's okay for her age, what can I do with those eggs in the future? So
I think the challenging part there is, you know, there's a nice paper by Jamie Griffo and the folks at NYU looking at utilization rates, but we really don't have a lot of outcome data on elective planned oocyte cryopreservation. And we're mathematical modeling that people are using to give patients estimations of what it's likely to look like at the other end when we go to thaw those oocytes. But I have a bad feeling that there's going to be a lot of patients disappointed, because right now only 15% of patients who freeze their eggs at Boston IVF have come back to use them. So we have a lot of stored eggs, and you know, it's going to be disappointing, especially for those older patients.
But they are not infertile patients in the first place, so that's why probably they will not use their eggs, because they will conceive naturally. Who knows? That could be a reason.
I would like to make a comment on the utilization rate, okay? Because this has been said by many that women, for the most part, don't come back. This does not mean that fertilization preservation has not helped them. Right. Sometimes to actually relieve the stress allows them, I'm gonna make it this a little French way and maybe not politically correct, but this is gonna probably allow them to go from looking for Mr. Right to actually falling in love with Mr. Not Too Bad. Yeah. And so it may help even if they don't use it.
Go ahead.
Yeah, we do quite some vitrification of oocytes here in the center, and what Dominique says is exactly the return that we have out of our patients. So we counsel them very correctly, and each and every of these ladies is aware of the fact that we can give no guarantees, but they really have a peace of mind knowing that they did what they could, and it really helps from a psychological point of view. And the return rate is not that high because many of them conceive naturally, but when we ask them afterwards whether they regret of having done this is not the case at all. It's a very, very important remark, I think.
Yes, I absolutely agree. I think that, you know, it's just important, especially for our older patients who are freezing their eggs who are, you know, in their late 30s, early 40s, and feel really positive that they've frozen 15 eggs. And it sounds like a lot. And then, you know, when they come back, unfortunately, as we see, the thawing, fertilization, blastulation rate is lower. And I've had, you know, the opposite of patients who said, I was falsely reassured that I had eggs frozen and I was holding out for Mr. Right because I had the luxury of having these eggs frozen, or so I thought. So putting all your eggs in one basket, so they say.
Counseling is
in terms of talking about oocyte quantity and quality and AMH, I want also to convey a comment from a paper we had several years ago when I was still in Switzerland, indicating that AMH does not predict women's fecundity. We had looked at AMH in women who attempted to become pregnant and had done something very smart. They had stopped taking the pill, okay? And we looked at the time it took them to conceive, anywhere from 1 to 15 months. There was no, an AMH measured before, there was no correlation whatsoever in all these women who conceived and delivered. There was no correlation between their AMH level and the time it took them to conceive. So women who come and now they're being panicked and they measure the AMH at the age of 30, it can be high or low, but does not predict fecundity. Just pretty much like body height, not a prediction of intelligence. I mean, this reassures me because I'm not very tall, but this is again variability.
After a certain
not
age.
everyone is.
I think that's an important point, and one of my all-time favorite reproductive medicine articles was published by Ann Steiner in JAMA in 2017, and looked exactly at that. Look at patients who are planning to conceive over the subsequent 12 months and demonstrated what you just said, Dom, that AMH was not predictive, and ovarian reserve markers in general were not predictive of fecundity. So that's important for our patients, especially those who are planning on getting pregnant in the near future. It's a very different situation for those with low ovarian reserve who are not planning on conceiving for many years.
So given that actually we are still 8 minutes left, so I'll leave you just a few moments to try to make some conclusions for the end of the discussion for each of you. I will just make 2 announcements. So the first one is that the Best of ASHRE and ASRM Congress will take place in March. So this is an event that takes place every 2 years. It's one time in Europe, one time in the US. This time is going to be in Orlando, United States. It's going to be held between 2 and 4th of March. And the second announcement is that the next journal club will actually happen during that meeting. So the 2nd to the 4th of March in Orlando. So we count on you and your presence there. And I think it's going to be very interesting. So look it up. So now, please, we're going to start with the authors. Or no, let's go for the ladies first. Shari, what's your conclusion on the discussion of today?
So again, congratulations to the authors. You did a very good job. I think it's extremely important information we have now in our consultation boxes to reassure patients that have a blastocyst to test that they perform equally well, no matter how many oocytes were present in the beginning of the cycle. But we need to be aware of the fact that it does not cover the entire spectrum of what we see in clinic, and that the study only started upon these blastocysts to test, but very reassuring and important counseling information. Congratulations.
Cindy.
Yes, yes, exactly what Shari said. It's, as I said before, it was really, it's really good to have these consistent data, which are real data. It's not only your opinion as a clinician to show patients, and it is, thank you so much. We hope to have more and more publications like these, because they give you actually, precise information that can be really useful, and not, just abstract data that are quite useless for the man in the street. So thank you so much.
Yuval and Denis, do you have some key points to underline?
First of all, thank you very much for your words. I think, again, that our most significant limitation here is that our study is prone to this survival's bias. Those embryos that did not reach into blast stage are simply overlooked. And that's not only in our study, that's in every other retrospective study. However, this notion does not limit our generalizability. It just limits it to the specific scenario, again, that when a patient, which is a DOR, diagnosed as a DOR or poor Vaughan response patients, reach to a blast stage, her chances are similar to her peer with another non-DOR diagnosis. And that's the essence, I think, of our data.
Yeah. And
Go ahead, Denis.
No, I just was saying that I would, use this data along with the EVRMA data to really encourage our patients to help counsel that not only not to be too upset or disappointed if the first cycle doesn't work out, that if they are persistent and show tenacity, that eventually a large proportion of them will have success. And so I think that's reassuring for patients who either have diminished ovarian reserve or who don't get a euploid blastocyst on the first cycle.
This was a great journal club, a journal club in Europe. I want again that we all convey our best wishes to Micah Hill, who actually was in charge of the journal clubs and was the first one who actually contacted me to have them also in Europe on the European time. This was a great experience, and we're going to continue that. Fertility and Sterility is a great journal. It's an international journal. We're all under the guidance and of Kurt Barnhart, and this is a fantastic journal. The journal club is an extension of our journal, and we may have journal clubs being held now also in other places in the world, not just Europe and the US, but possibly Asia and elsewhere. So again, thank you all for participating. Thank you, Paul, for directing this discussion. Thank you for the authors. Thank you for the ladies. You did a superb work. Last but not least, superb work in discussing these articles. Quality and quantity, two different things. What counts is quality, not quantity. Thank you all. Thank you for the organizers at Fertility and Sterility who were behind the screen and actually made this possible. Tia, Ryan, thank you all, and have a good evening and your great day if you're in the US. Bye-bye.
Thank you. Have a great night.
Have a good night.
Thank you.
Bye.